Welcome to Healthy Frontiers. My name is Dr. Bisogni. I'm a chiropractor, and this show is dedicated to the education of our viewers. The topic for tonight is help for hearing loss. My special guest is Dr. Jasen Ruiz. Dr. Ruiz is the Chief Audiologist at Advanced Audiology of New York, and I'd like to welcome Dr. Ruiz to the show.
Thank you for having me.
Oh, it's my pleasure, Doc. We're going to start. Why don't we a lot of people don't even know about audiology, I'm sure, as they don't know about chiropractic. So it's always good to explain, right? So
Absolutely.
Why did you decide to go into the field of audiology?
Well, I really didn't know. I always knew I wanted to help. I always wanted to be in the health field. I always wanted to help others. Before I started audiology, I had to take speech and language pathology classes, and in undergrad. I actually graduated from my own college, local here in New Rochelle, undergrad. And then in order to become an audiologist, you have to take those speech and language pathology classes as well. They work hand in hand with each other. So I found my calling. I knew this is what I wanted to do. I knew it was black and white. You have a hearing loss, this is something we can do. So this is the reason why I decided to go that route.
That's great. So what are some of the requirements to become an audiologist?
Sure. Well, in undergrad, we did 4 years. My undergrad degree is in speech, language, pathology, and audiology. And then we have to take the GRE to get into grad school. It's a 4-year program for a doctorate program. Actually, in 1997, they required, 2007, they required all audiologists now to get their doctorate. And you can have either an AUD, PhD, or an SED, like what I have. It's a Doctor of Science in Audiology.
Great, great. And I know you guys work very much hand in hand with the medical profession to come up with the proper diagnosis and treatments and what have you.
We work closely with ENT doctors, primary care, pediatricians, PT for balance and dizziness. So we work closely with all those professionals.
So, okay, so what exactly does an audiologist test for?
That's great. So basically we do diagnose hearing and hearing loss. We also do balance and dizziness testing. Many people forget that part. Audiologists, we actually can find out what's wrong, how come the patient's feeling dizzy, is it vertigo? We actually work closely with primary care doctors and PT to make sure that we're able to either prescribe vestibular therapy or find out exactly what's happening. Why is this person feeling dizzy? And of course, hearing loss, if the person has a hearing loss, what type of hearing loss the patient may have. And then if they have sensory neural hearing loss, we want to fit them with the proper devices.
Right, which brings us on to the next question, which there are different devices to aid people in hearing. So what are the different types of hearing aids that are available to the public?
Well, there are many, many different manufacturers out there, and usually the way I do it is based on the patient, and I usually like to make sure that the patient's very educated. I want to get the family involved. I want to make sure we pick the right device for that person, depending on how active they are, depending on the dexterity of their fingers, depending if they're able to actually open that battery door. And they have all different types, from the smallest, which is the CIC, all the way to the largest, which is the BTE. Some of the older devices here, this was actually, I just brought it as an example, like a horn. Right. Back in the day, you might have seen that in some of the movies or cartoons, and now they have complete invisible devices, such as this one over here. It's fully digital. It goes down to the second bend of the ear canal. Really, this is very, very comfortable because, again, it's made specifically for the patient's ear. And then this last one over here, this is called the Lyric device. This one's completely invisible. The patient doesn't have to worry about changing batteries. The patient can actually shower with it and go swimming with it. So it's really helped and changed the way people look at hearing devices, like those old ones that they had in the past.
Yeah, sure. I would think, you're dealing with many seniors in this world of hearing loss, and, you have to address that too, right?
All age groups, from infants all the way to geriatrics. I mean, at our office, we see babies a couple of weeks old all the way to my oldest patient is 104. And we count everyone that are in the hundreds. We have one that's 104, one that's 103, 101, and now in 2 weeks we'll have one that's going to turn 100. So we keep counting. We do like a little special party at our office.
That's awesome. That's great. So, okay, we're talking about seniors in the hundreds.
Sure.
So is there a correlation between hearing loss and, say, dementia and diabetes, which diabetes is huge in, older people?
Sure. Dementia, I think one of the biggest things, actually, it was just a study in Johns Hopkins stating the reason why dementia is correlated with hearing loss is because people feel isolated when they have hearing loss, when it's untreated. If a patient feels like they don't feel like going to restaurants, or they feel isolated, I feel tired, I don't want to go to dinner today, it's because they're not hearing. And when they become isolated, then that comes hand in hand with dementia. Same thing with diabetes, just the flow of the blood and circulation, that all has to do with, again, the cochlea here which is right over here, we need to make sure, I mean, we've seen studies after studies, not only diabetes, high blood pressure, all these different signs that are related with hearing loss now.
Sure. Okay, so we talked about the senior group. How about pediatrics, and
Sure.
how common is it in the younger group?
So I think what's more common in the pediatric group would be conductive hearing loss. And conductive hearing loss is, it can be anything from just wax or an ear infection or any type of fluid in the middle ear. And these are the type of examinations we would actually find out what type of hearing loss this person may have. Is it just wax? And that's something that we can actually remove in the office very, very easily. We have a lot of peds that, because their canals are so narrow, they can really get clogged up with that debris. So we have to remove that. I actually have a 13-year-old. We have to remove the wax monthly.
Monthly.
Yeah, so it's difficult.
Yeah.
Some people every 6 months. It's very subjective depending on the patient.
Right.
But again, peds are more conductive. If it is a sensory neural hearing loss, meaning if it's a permanent hearing loss, then we would fit that patient with hearing devices.
Okay, that's great. So at your facility at Advanced Audiology of New York, and in nursing homes, is some of the services that you do there?
Sure. So we're actually really work closely with some of the nursing homes here in White Plains, as well in New Rochelle, Yonkers, and Mount Vernon. Basically, if the patient has wax, we are able to actually go in and remove the wax, but also we're able to do hearing evaluations at the nursing home, and we're able to actually prescribe hearing devices at the nursing home, just to make it a little bit easier for those seniors that cannot make it to our office. It's just, it's a one-stop shop. So it's not only what we can do at the office, but also what we can do at these nursing home, assisted living places, and so on and so forth.
Gotcha. You know, we keep talking about this wax buildup and removing the wax. Just
Sure.
a question here. You said sometimes people have to be seen weekly, monthly, to
Sure.
remove the wax. Is there a genetic factor for wax buildup, do you think?
Well, it all depends on the patient. Some people really just produce more wax than others, and it's natural. It's actually considered a protective feature. We're supposed to produce wax. But when it gets to the point where it's completely impacted, it actually can affect the hearing.
Right.
And we've seen this time and time again where the canal is completely impacted with debris. There's really no genetic correlation to it. Some people do just produce more wax. And it's funny that you mentioned that. Some patients actually produce more wax in one ear versus the other. Sometimes it's the other way around as well.
Okay, great. Okay, so what are some of the psychological and emotional effects of hearing loss, which is huge, I'm sure?
I think it goes back to the dementia again. Patient feels isolated. Let's say we're asking mom and dad, Mom, would you like to come to the restaurant today? We're going to have fun. We're going to celebrate the children's birthday, whatever the case may be. And the grandmother or the mother may say, no, thank you. I'd rather just stay home. I'm feeling tired. They'll give any excuse not to get into that type of situation because they want to avoid not hearing. They want to avoid embarrassment. They want to avoid having people repeat, and that's I think that's the most critical thing when it comes to hearing loss. People are having others repeat, speaking louder. And one thing that I do want to stress is the fact that because a person has hearing loss, doesn't necessarily mean you have to speak louder. You just have to speak slower and clearer, and just to make sure if you can have that patient look at you, use your visual as well as your auditory, it's going to make life a lot easier. Right. But of course, if you have hearing loss, we definitely encourage you or have the family encourage the person with hearing loss to come into the office, because this is something that we can take care of very, very easily now these days.
Gotcha. Okay, so let's be a little more analytical here. And what are some types of hearing loss?
Sure.
Are there,
so there's actually 3 types of hearing loss. The first, which we spoke about a little bit, is considered conductive hearing loss. The second is sensory neural hearing loss. And the third is a mixed hearing loss. So as you can see, from the definition, mixed is a combination of both conductive and sensory neural. Right. Now, let's say if someone has a conductive hearing loss, that basically would consist of the middle and outer ears. So if there was wax in the canal here, or maybe there's some fluid, that would be considered a conductive hearing. It can cause a conductive hearing loss. And this time, if the patient does have conductive hearing loss, if the audiologist is able to remove the wax, perfect. But let's say if there is fluid, then we would definitely refer either to a primary care doctor, to the ear, nose, and throat right. doctor to prescribe medication at that time, or antibiotics. Right. Sensory neural hearing loss actually has to do with the inner ear. So here's the cochlea, which are there's thousands and thousands of hair cells here, or cilia, that represent the different frequencies that we hear, low, mid, and high. Low frequencies is usually where we get men's voices. So most of my patients come to my office and say, I can hear you perfectly. I don't have a hearing loss. I'm like, well, your hearing loss is actually in the high frequencies, and that's where we get women's voices and children's voices. And some of my male patients say, well, that's good. I don't want to hear the wife anyway. But and then the sound is sent from the cochlea to the auditory nerve to the brain. So we actually don't hear with the ear, we hear with the brain. The sound is sent from the ear to the brain, and that's how the whole thing works together.
Right. Okay, so in general, so the conductive hearing loss is, just say what that is.
So conductive is more of a temporary loss. This can be just wax or fluid or ear infection, which can be easily treated.
Versus
sensory neural is something that's permanent. There's no surgery, there's no medication, there's nothing that can be done at that time. The only thing that we can do is actually help the patient with hearing devices or hearing aids.
Gotcha. Okay, so why should physicians always encourage an annual hearing exam? I mean, it seems obvious.
It seems obvious, and many people come to my office, well, my doctor never told me to get a hearing test, and the reason why is because hearing loss is not associated with pain or discomfort. This is something that happens gradually throughout the years. So a lot of my patients may come in, they might have not had the hearing test ever, or maybe elementary school, and they say, I don't feel like I have a hearing loss. It feels like it's been fine. The people that notice it most are the people that are closest to them, their children, their spouse, a close friend. But what happens is once we actually get the hearing devices in the ears, and then they say, wow, it's so loud out there. I was like, welcome back.
Yes,
it was always that loud.
Sure.
The car, the dog, whatever, the birds is a big thing that we hear. And of course, when they go to the bathroom, they tell me it sounds like Niagara Falls. So but that was always like this. You just have to really learn how to hear again. And we call it the oral rehabilitation, retraining the brain how to focus on the sounds you want to hear and ignore the sounds you do not. And the quicker, the more proactive the patient is, the easier the whole process is as well. So.
Great. Okay, so I think you said before that some conditions are permanent.
Sure.
Is it permanent once you lose your hearing?
Once you lose the hearing, I always tell my patients, if you don't use it, you lose it. And what happens is once there's a sensory neural hearing loss, depending on the severity of the loss, because there's mild, moderate, severe, and then profound losses. So for those patients that have profound losses, there may be something different that we have to prescribe, such as a cochlear implant, and that we work closely with an ear, nose, and throat doctor in the hospital. That's the one thing that we don't do in our office because you have to have a hospital setting. Right. But if it's a hearing loss, we can definitely help with hearing devices, and we recommend to get it sooner because we can actually prevent auditory deprivation, meaning depriving the brain of getting the stimuli the way it's supposed to be. So we definitely want the patients to be more proactive, get the help sooner before we get to the point where we can't help them.
Right. Always to find it and stop it if you can. Right?
Absolutely.
Okay. So tell me some of the causes of hearing loss.
So the number one cause of hearing loss is presbycusis, meaning as we get older, the hair cells, unfortunately, of the cilia actually tend to fall off. Of course, as we get older, the bones get weaker. So this whole system all acts within each other. So the number one cause of hearing loss is presbycusis. As we get older, we start to lose our hearing. But now, very popular, you've seen it in the news, actually Bloomberg actually tried to make a law to decrease the volume on radios and iPods. But the number two reason is one in five teenagers now have hearing loss due to noise exposure. And again, noise exposure can cause a permanent hearing loss. So we definitely recommend to all children, or to everyone, turn down the volume. And when you're at the gym, protect your hearing. It can be either when you're at construction. I've seen so many people with now the leaf blowers and just any time when you're around loud sounds over a long period of time, it can definitely cause a hearing loss. And now our population actually is decreased. I have many patients that are in 30s or in 40s that worked in construction in the past, or maybe sheet metal, and it caused a permanent hearing loss. And at that time, now thank goodness we're able to help them with hearing devices that are pretty invisible.
So, and it gradually gets worse, is what you're saying. Once it gets started, say you were in this construction event and you started to lose hearing.
Sure.
So if it's not addressed, it's going to get worse. But you're saying you can't stop the progression of that by getting to, in many cases.
There are studies where we're able to actually have the hearing devices in. We're stimulating it. What we normally recommend for patients is put the devices in the morning, keep them on all day, and at nighttime take them out. Of course, you're going to take them out when you take a shower, when you go to sleep, and when you go swimming for the traditional type of devices. But the extended wear device, the Lyric, you can actually use them all the time.
Okay. So how can you prevent hearing loss?
Prevent hearing loss. So when it comes to presbycusis, age, we cannot, there's no fountain of youth. We can't stop that part. But the second biggest reason, noise exposure, definitely use hearing protection. And definitely like Con Edison and MTA workers, all these people wear earplugs, and we definitely recommend doing that. Again, decreasing the volume on the radio, the TV. Even though they have these huge surround sound systems, you want to definitely decrease it. Exposed to those loud sounds over a long period of time. It's definitely
Do high sounds make it worse than lower sounds, like say a bass? versus a tenor kind of situation?
Yep. So we definitely test all frequencies. The human ear can hear from 20 hertz all the way to 20,000 hertz. When we test in the office, we test from 250 hertz to 8,000 hertz because those are the speech frequencies.
Right.
Low frequencies being the vowels, high frequencies being the consonants. When there is a high pitched sound, it definitely will affect the high frequencies, but that bass boom, 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 boom would definitely affect the lower frequencies. So even a sudden explosion could definitely affect the low and mid-high frequencies as well. Absolutely.
Right. Does anything get, if there is a loud explosion, what does happen in something like that? You know, if someone's right next to a loud explosion and they go, I've been deaf ever since.
Yeah, it has been trauma to the ear. That can definitely bring trauma to the ear. Another thing that we've noticed with patients that have been exposed to loud sounds is something called tinnitus, or some people call it tinnitus, either or. Tinnitus is basically ringing or a roaring sound, or it could be a hissing. It can be any different type of sound that they didn't hear before. Many patients, there may be more than 2 million patients across the United States that suffer from that tinnitus or ringing in the ear. And they go into these doctors' offices or primary care doctors and tell them, and the doctors tell them, well, there's no cure, there's no medicine, there's nothing. Well, I'm here to tell you that there is something we can do. There's something called tinnitus retraining therapy. This was actually developed by Dr. Paul Jasen from Towson University in Maryland. I was trained back in 2007 again for this TRT, and we're able to actually train the patient not to focus on that ringing. We're able to actually work with TRT and sound therapy so the brain can focus on something else instead of that ringing. And we've changed a lot of people's lives. I've had patients that experience ringing or tinnitus for 18, 20, 25 years, and finally they were able to come into the office. Right now, I think we're able to fit at least 8 to 10 people and help those people. And those 2 out of the 10, at least there's something that they didn't have before.
Yeah, and what usually causes tinnitus?
It can be either loud sounds. Sometimes it's definitely associated with hearing loss. Many times we're able to help patients with tinnitus if we're able just to first help them with their hearing loss, because now their brain's going to be stimulated with all their environmental sounds and all the sounds around them. So if the brain is focused on that, they may not even hear the ringing. Some people can just ignore the tinnitus altogether, but then they have that small group that they do suffer from the ringing, and it's hard for them to sleep, it's hard for them to concentrate or even read a book. High blood pressure, high amount of caffeine, ototoxic drugs such as aspirin, all these different things could definitely affect that tinnitus. And it could be a combination. Unfortunately, it's just not one thing that we can say that causes it.
Right. But once you have it, in your case, it almost doesn't matter what caused it.
Doesn't matter.
You can treat it by retraining the brain.
That's
what
it.
You're saying.
That's the goal. We want to actually retrain the brain. We want to introduce sound therapy, and we help a lot of patients with that.
That's great.
Very, very successful.
That's great. Okay, we're just going to go back to the wax situation.
Sure.
It's so common, all right? So
people
will also go in there and, you can go into a drugstore and get some drops, or you can try and get it out with a Q-tip.
Yeah.
So is it dangerous to use a Q-tip? Does it work?
We definitely don't recommend Q-tips.
Okay.
The reason why we don't recommend Q-tips is the fact that when you use Q-tips, first of all, it can be very dangerous. You can actually puncture the eardrum, the tympanic membrane, which is very, very close. But also, by using the Q-tips, you're actually pushing the wax deeper into the ear canal. By pushing the wax deeper into the ear canal, you actually make my job or the ENT job even more difficult to remove it. Also, it just really disturbs the way that the ear actually removes the wax by itself, because this happens naturally when you do take a shower. We definitely recommend just to clean the outer portion of the canal. If you want to use Q-tips, maybe just the outside of it, but never put anything inside the ear canal itself. Or you can use clean the keyboard with that Q-tip. We never recommend putting anything in the ear itself.
Understand. Now, how about the drops that people buy over the counter?
Yeah, there's
Does
something.
That work? Hydrogen.
Yeah, hydrogen. Yeah, well, hydrogen peroxide, just pure hydrogen peroxide could actually just dry out the ear. We definitely recommend something called Debrox, and that's a diluted hydrogen peroxide. And depending on the patient, I would like to see the patient at least the first few times to see if we have to recommend them flushing the ear monthly or weekly. But hydrogen peroxide really does help, especially for those patients that are mild, that have maybe a little bit of wax, then they can use that. But most of the time, we're able to flush or even suction that wax out in the office, which makes it really, really easy.
Right.
So,
right.
Yeah.
Do people usually have pain when they're having these problems at all?
It can be very painful. Actually, 2 months ago, I had a 30-year-old saying, I cannot hear anything. It was completely occluded. And then he actually used the Q-tip, and the end of the cotton swab, or the end of the Q-tip, actually got stuck in there, so it made it even worse. So he came into my office, and it was completely occluded. First, I had to remove the cotton swab, and then I was able to remove the wax, and it was like night and day. He said, I can hear again. It was like a miracle. It really wasn't a miracle. We just removed the wax.
Gotcha. Okay. So, all right. So, what are some of the typical signs of hearing loss? I mean, I think we touched on that a little bit.
Some of the typical signs, you would see mom and dad basically have people repeat, what did you say? Also, they may even actually increase the volume in the television. Actually, one of the first things I usually ask my patient is, have you increased the volume of the TV? And they say, yeah, but it's comfortable for me. But the child, hopefully either the spouse or someone else says, it's too loud. Actually, you can hear it blaring from outside the hallway. So that's one of the first things. Also, over the telephone, if you feel like they're refraining from speaking over the telephone, or they have the volume on max and they're still having people repeat, that's also a sign. And again, also isolation from those different situations that they used to do before.
Yeah. Okay. So, you talked a little bit before about being able to test infants to people in the hundreds.
Sure.
Right? So why is it important to test infants? And let's talk about that a little bit.
Sure. 1999, they made it a law, mandated within the tri-state, that all children born within 24 to 48 hours need to be tested for the hearing. And we call this otoacoustic emissions, it's OAE. And basically, we just place a small tube right into the ear while the baby is sleeping. That actually, pro tip, actually is able to send a sound to the cochlea, and the cochlea actually sends an echo right back into the pro tip, and we're able to read to make sure those outer hair cell functions of the cochlea are functioning the way they're supposed to be. And the reason why it's important and the reason why it's mandated is because now we can actually see if that child or infant has hearing loss prior to school age. And if the child does have hearing loss, we're able to actually fit the child either with hearing aids or a cochlear implant, and be able to actually, that child will be able to actually attend normal hearing school when it comes to kindergarten and first grade.
Okay, so when they're younger now, now we're out of the infant stage and they're younger in school, and a lot of kids get ear infections. It's so common.
That's very
common.
Does that
cause hearing loss?
Yeah, depending, especially if the child has continuous ear infections, especially if the child is just maybe every few weeks has an ear infection, it can definitely cause hearing loss. So this is the time when we can do tympanometry to see if that eardrum is mobile.
What is that?
It's called tympanometry. And the reason what we're testing here is to see if this eardrum is mobile. We want to make sure that the eardrum is moving the way it's supposed to be. Also to make sure there's no fluid behind the eardrum. If there's any fluid behind the eardrum, that can also cause a conductive hearing loss. But we work closely with the pediatrician as well as the ear, nose, and throat doctor to make sure they can prescribe any antibiotics to clear that fluid or any type of infection that they may have at that time.
Would you want to touch on why, a lot of times these tubes are recommended for children?
Sure. So what happens, if it's continuous ear infections, if let's say the wax or the fluid is not draining, then they would actually put a tube, a PE tube or pressure equalization tube, so that fluid will be able to drain out. And what happens, the reason why children are so prone to ear infections is the fact this is called the eustachian tube.
Right.
And this eustachian tube is very vertical as adults, but as children it's still very, very horizontal, so this fluid is not able to drain out the way it's supposed to be, or it should. As adults, we rarely see patients that have ear infections, more as infants or children.
So the change in the angle is what you're saying.
Correct.
So that the fluid will drain properly, and that's the problem with a lot of these kids.
That's exactly what happens, and this is what we see all the time.
Okay.
And it was just, it could also be genetics. If mom and dad always had ear infections, there's a possibility that their child also may have ear infections.
Right.
It all depends on the anatomy of the ear.
Okay, great. And can hearing aids help with speech clarity? We're on to a whole other topic
This
now.
is a whole other topic.
Yeah.
I think most patients, some of the older devices, the analog devices that they had in the past used to make everything loud. Not only speech, but as well as all the background noise. And they used to have lots of difficulty hearing or deciphering speech from the background noise.
Right.
Today's digital devices, they call them a little bit more smarter. The reason why is because they have directional microphones where the device is able to pick up the speech and increase it over the background noise, or if it has a directional mic, is able to actually focus on the person that's speaking and then be able to decrease that background noise behind them. So all this is happening automatically without the patient having to do anything. There's really no more volume controls. They have volume controls, but some of them are fully automatic where you don't have to do anything. And the speech clarity will be there, and we're able to actually decrease that background noise and focus on the speech.
Okay, so before we wind up, we're starting to come to the end here.
Sure.
I just want to ask you, what are the newest and greatest hearing aids out there available for people? I know the big problem in growing up, I remember young with my grandma and my mom, these big hearing aids, and I'm not wearing that. And
Sure.
so are there small, and I know there are small devices that can do it all now?
Sure. So some of the other devices that we have, I just brought a few examples of them. This is what you call an IIC, or invisible in the canal. It's fully digital. It's actually, we take ear mold impressions. We take an ear mold impression down to the second bend of the ear canal, and we're able to fit a lot of patients. It's completely invisible. So
Right.
I think one of the major factors that patients, I think I'm old. When I have a hearing device, it's totally different. No one will be able to see it.
Right.
Vanity is not an issue anymore.
Right.
So this would be one of the latest and greatest. Another one would be the lyric device. So this is actually placed down to the second bend of the ear canal as well. This device is great, and we've seen a lot of patients. Our office is actually the #1 practice in Westchester. We've fed many, many patients with this device. And the reason why it's so popular is because they don't have to worry about touching it. It's basically the contact lens of devices. They don't have to worry about changing batteries, cleaning it. It makes life a lot easier compared to what old devices that they had in the past.
Right. And when people get these devices, usually both ears, or is it sometimes one ear?
Yeah,
I mean,
at least 90 to 95% of the people who ever get hearing devices, really, whatever happens to one ear happens to the other. So most of the time we have to fit. But sometimes, let's say if it's a younger patient that had some type of trauma, had an accident, a car accident, or a fall, sometimes that would affect just one ear. And in that case, we would only fit that ear. Also, in some cases, if one ear, the hearing loss is completely profound, and the other hearing loss is something like moderate severe, then we will actually fit just that one ear, depending on their speech discrimination and clarity.
okay, that's great. So in conclusion, what else does an audiologist do?
Sure. So we do a lot of things. I think I play a lot of roles, a lot of hats. Psychologist, working with spouses. But I think it's just really hearing loss, treating hearing loss, balance and dizziness, tinnitus retraining therapy. There's a lot. I mean, there's an industrial audiologist, educational audiologist. There's all different types of fields, and this is another reason why I decided to go into this field, because there's different branches where we can actually go into.
Well, that's great. And you're constantly working with the MD.
Absolutely.
So, if there's a problem there medically, coming to an audiologist as the first portal is fine.
Sure.
And then if you think you need medical attention, you certainly
Refer them.
refer back to their medical doctor, and everybody works together
That's
for the
100%
benefit of the
correct.
patient, correct?
That is 100% correct. I mean, that's something that we see. Why would I go to an audiologist besides an ENT? Well, if it's a sensory neurohearing loss, the ENT is going to refer to the audiologist anyway.
Right.
And you can save on that second copay.
That's great. Well, Dr. Ruiz, thank you.
Thank you so much for having me.
Oh, it's my pleasure. And I want to thank Dr. Ruiz for being here, and it was greatly informational. So look forward to seeing you on the next show. If you have any questions for Dr. Ruiz or for myself, please send us an email, and we'd be happy to answer those questions. Thank you very much.